Okay, and we are back from technical difficulties. I'm happy to welcome our 4 panelists for today's discussion about what you can do with family medicine. I mean, of course, the first answer is a lot, but we're going to get into some more specifics. I've got 4 of our members from 4 very different walks of life, and this isn't the order they're going to go in, but as a quick summary of who they all are, they'll introduce themselves, a little bit about how they found their way to where they are, some important things to know about what they do, and take your questions. And then I'll wrap up with some extra resources that are available to you from AAFP and IAFP. So let's get going. Our first presenter is Dr. Tom Cornwell. Dr. Cornwell, the floor is yours.
Thanks so much for this opportunity. I just love family medicine. It was one of the smartest choices of my life to go into family medicine, despite, as I'm sure was the case for you, being dissuaded in medical school to choose it. But it was, again, just a great decision. And it is a absolute fantastic time for family medicine with a shift in our country to go away from the fee-for-service paying for volume, paying for procedures and paying for surgeries and paying for heart attacks rather than paying to prevent them. But things are really changing because we produce value. So there's this equation here. Value is quality plus service over cost. And procedures are high cost and don't always get us the quality we want. And again, prevention, which is what family medicine does, is so much more value. And the exciting thing, and I'm not sure if you've heard about this, but CMS by 2030, they want all Medicare patients to be in some type of a value based payment. And even when you look at, there's this thing called the CMMI, the Center for Medicare and Medicaid Innovation. When you even just look at the programs that they have developed in 2017, Comprehensive Primary Care Plus, 2021, Primary Care First, 2023, Making Care Primary. They really want to support primary care. They want to pay more for it because they know they get more bang for their buck. And then I chose in 1993 to start making house calls as a mission to homebound people, but it was a huge struggle. In fact, some of you at Delnor are probably going out with the program that I started, Home Care Physicians at Central DuPage Hospital. But it was a struggle. I appreciate Northwestern support, but it was always a struggle because not only did it lose money doing house calls, but it actually kept patients away from the hospital. So the hospital lost money from that also. And one of the things I just want to show on the bottom left here, that when you talk about value-based care, where the greatest opportunity to reduce costs is your most expensive patients. And healthcare costs are incredibly concentrated, where you can see here the purple, 5% of patients consume 50% of the cost. And unbelievably, the sickest 1% consume 21% of the cost at an average cost of $127,000. And before I talk about house calls, which is my next slide, I just want to just show you the difference it has been for me. In the last 4 years, I joined a value-based company. They've asked me to spread house calls across the country. When I was doing my work at Central DuPage Hospital, on the bottom right, you could see the maximum I could get for 500 house call patients. If I billed fee for service really well, I could make $1.2 million of revenue. Under value-based care, we're paid a certain amount of money to take care of these horribly sick people. And then we have to pay for their hospitalizations. We have to pay everything for them. But instead of 1.2 million, we get 16.3 million for those 500 patients. And Medicare, that might sound like a lot more money, but Medicare is not real generous in paying for fee for service. They're not super generous at paying to take care of all their costs. But what this does is it gives us just incredible flexibility to do things that are just remarkable for these patients, and it's all paid for with what they want, which is to keep them out of the hospital. So it just is such an exciting time for family medicine. Next. And so just in terms of what I've been doing, next slide. Um, the so in 1993, I started doing house calls to homebound patients. I actually had a van that had X-ray in it. We actually developed the X-rays. There was no digital photography back then. We developed the X-rays in the driveway. It was quite remarkable. But I was basically an emergency room on wheels. But these are just things now. You guys probably have heard of the butterfly IQ, but ultrasounds can fit in your hand, and then you use your phone as the screen. X-rays can be done. The bottom right picture is a person on home hemodialysis. So not only is there diagnostic equipment that I can use for taking care of people, but then there's also therapeutic uh, um, increases in terms of things that can be done in the home. But the one story that I want to give you is that in terms of again under value-based care, we we are financially incented to keep people healthy. Under fee for service, the more your patients smoke, the more they drink, the more they don't wear their seatbelts, the more they do bad things, the worse they eat, the sicker they get under fee for service, the more money you make. They have to get sick in order to bill them. Under this value-based care, and this was a patient who had been hospitalized 6 times in 4 months at, Elmhurst Hospital. You can see that she's lost her right foot and her left, above the knee amputation, and I was asked to go out to see her because she could not get out to a primary care doctor, and the hospital said she had to go to a nursing home. And so I thought she knew why I was coming out, and when I mentioned that, she got incredibly distraught, just horribly distraught, because she didn't wanna go to a nursing home, and one of the things part of, I'll tell you that house calls have been shown to reduce nursing home placement 87%. And so our goal is to keep people out of nursing homes and out of hospitals, but the reason one of the reasons I found out that she was so upset was because she was born in Germany, and in the late 1930s, she found herself in a German prison camp. And actually part of the reason why she lost her legs all these years later was because of horrible frostbite. Well, once I found out she wanted to stay home, we were able to get her home health. She wasn't able to get home health because there was no doctor to order it. And we got her so much better. Next, can you just click one more time? That we actually got her so much better that we were able to send her to a rehab center so that we could actually get her new prostheses so that she could actually walk again. And so, in general, house calls have been shown to decrease hospitalization by 15 to 20%, decrease nursing home placement by 87 to 89%, and just incredibly improve end of life care. The program, and again, I'm sure the Delnor residents that go out with my former partner, Dr. Chang, and others, see this that 75% of our patients from since 2003, over 3,000 deaths passed away at home, which is what they wanted, surrounded by loved ones. And not only is this what they want, but there's huge cost savings by enabling them to be in their home rather than being in an ICU. And so, so that's what I had to say, Jenny. And I do apologize. I actually have a AAFP meeting on home-based primary care at the top of the hour. And so I appreciate Jenny you letting me go first. And I am going to have to check out pretty soon. But thank you for this opportunity, Jenny.
Oh, of course. Before you have to go, I thought I would just open the room up and see if there's anyone who wanted to ask a question specific to you before you have to go. And that way we'll have it recorded.
Are there any Delnor residents that have gone out with Dr. Chang, and what has the experience been like?
There's a question in the chat. Would you be willing to discuss salary expectations in your role?
Right. You know what's interesting about this value-based care is that uh, is that there's such opportunity to save so much money that that actually we are paying very handsomely for doctors that are willing to do this. It's not easy because generally doctors aren't trained, and so you're not always comfortable. We expect, you know, about 8 visits a day on these very sick patients, and so but you know, definitely, and even at Central Stage Hospital, Dr. Chang and I really made, you know, maybe a little less than the other primary care doctors, but it was definitely in the ballpark. But that's because it was subsidized by Northwestern. But
All
with
right.
value-based organizations, they're willing to pay for this because, you know, they know how much you save them money by keeping people out of the hospital, providing better end-of-life care and such.
All right, with that, we'll let you tag up. And just so everyone knows, the AAFP does have a member interest group on home-based care that Dr. Tom Cornwell is the chair of and is heading that way. So if you log into your member account at AAFP.org, you can even add that to your list of communities to join. Dr.
And
Cornwell?
we're looking for leaders on the MIG. And so if anyone's interested in this, you can actually put that on your resume that you're a officer on one of the AAFP's member interest groups. There's about, I think, 30 member interest groups. And so that's something also to kind of look into. But again, thank you, Jenny.
Always great to see you. So have a wonderful afternoon, and I will pass the baton on to your former colleague.
Yeah.
Dr. Chicoine, the floor is yours.
So Tom turned out pretty well despite me being his chief resident when he was an intern. So good to see you, Tom. So I'm Brian Chicoine. I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center in Park Ridge. And this is our building there. We're on the campus of Lutheran General Hospital. We opened in 1992. And have seen over 6,000 adolescents and adults with Down syndrome. We were the first clinic for adults in the US, and we are by far the largest. Next slide. So my journey, starts at Lutheran General as did Tom's for residency. And I like to say that family medicine gave me the opportunity to have the practice I didn't know that I always wanted. This is the practice I always wanted, but I just didn't know it. So I trained at Lutheran and then went to practice out in Freeport, which is out in the northwest corner of Illinois, where a lot of my patients were dairy farmers, and I did the full gamut of family medicine, including OB, had a huge OB and a huge pediatric practice, was doing OB when the nearest obstetrician was 30 minutes away sleeping at home. And so that was thrilling, we'll say. So I did the full gamut. And then when I was out there, 2 16-bed residential facilities opened for adults with intellectual disabilities. And I became their medical director. So I cared for those 32 individuals. And then I came back to Lutheran to join the faculty here. And about the time I was coming back, the local parent group asked the hospital to start a clinic for adults with Down syndrome. They were finding that their kids were getting good care as kids, but not the same quality of care as adults. I'm not sure what your experience has been in residency, but when I was in residency many years ago, there was really, certainly in medical school, really no information and limited in residency about caring for adults with intellectual disabilities. So ended up on the chairman of family medicine's desk back in 1991, and then we opened the clinic in January of 92 and started 2 mornings a month. And I continued to teach in the faculty and do primary family medicine, including OB. And then the clinic just kept growing and growing, and I kept lopping off other things until this is pretty much what I do. And it really has been such an interesting opportunity, certainly the patient care, but also an opportunity to participate in research, to teach, a lot of opportunities to teach and to share information. And then as I move along in my career, I'm really getting much more involved in advocacy and health equity, because this really is a population that has been underserved for many, many years. During the pandemic, I got particularly interested in advocacy. The article there on the bottom right is about an individual with Down syndrome in her early 50s who had early Alzheimer's disease and was admitted with COVID pneumonia to the hospital. And after about 24 hours, deteriorated and ended up in the ICU. And there was lots of pressure by the ICU team to make her DNR, despite the fact that I had a conversation with her and her family that that's not what they wanted. And so after several days of being, I'll generously say, encouraged to make her a DNR status, I finally just said, look, there's no data that tells us that this individual is going to do worse than anyone else. And so they backed off, and she ultimately went home. But we wrote an article called Ableism at the Bedside, People with Intellectual Disabilities in COVID, about how that, how that was a problem. And then, as you may remember, at the beginning of the pandemic, there were a number of states did triage efforts to that would automatically exclude anybody with an intellectual disability from getting a ventilator if they needed it. And the federal government stepped in and said that's against the law. But still, a lot of that was still happening at the bedside. In fact, we had I had an opportunity to participate in another study that was like 800 hospitals. And if you got admitted with COVID pneumonia and had Down syndrome versus got admitted COVID pneumonia without Down syndrome and everything else being pretty much equal, you had a 6 times greater chance of entering the hospital with having a DNR label at the time of the admission. So there was a lot of not providing the same quality of care to people with intellectual disabilities during the pandemic, unfortunately. But also had a lot of opportunities to, we've seen so many people, seen more than any other people in the country. So we've had an opportunity to, gather our data and share that. So we have an article in the top about the prevalence of common disease conditions in people with Down syndrome, and then a lot of opportunities to teach not only families and professionals, but also people with Down syndrome. And so we really look at it not as that they learn, but how can we best teach them? And so people with Down syndrome tend to learn better by videos or by visuals. And so we have a lot of visual patient education material. And you can see on the little thing there on the left, or up in the mid there on the left, all our patient education videos have people with Down syndrome as the actors and actresses. So it's not only a lot of fun to make, it just has, it works better as a training because the people speak and look like the people that we're trying to teach, and it seems to have a real value to do it that way. So really, I have been very fortunate in family medicine to really get to do a wide range of things for a unique population. Next slide. And so this is, again, we have a lot of information to share. If you're interested, take a look at that. We have our online resource library, an email list, a Facebook and Instagram page, and share lots of information about caring for adults with Down syndrome. So I like to say that, when I was practicing in Freeport, was I really trained in Park Ridge for practicing in Freeport? Well, probably not completely, because I remember the pig farmer that came in and he had been inoculating his pigs, and the last one bucked just as he was on the downstroke, and he stabbed himself with the needle. So I can't say that I'd ever seen a pig needle injury in Park Ridge, certainly, but I think we were taught, family medicine really teaches an approach to the patient, which I think is the key. I looked at it, I've, presumed it was, staph or strep probably from his own skin, but I called the vet and said, is there like piggy AIDS or anything I should be worried about? And there was no piggy AIDS to be worried about. And there was nothing in the vaccine that, was problematic for him. So, we treated him with the usual antibiotic that you would for a cellulitis, and he got better. But again, I think the key that wherever you practice, I think you've learned an approach to the patient. I think that's so valuable. And then certainly with folks with Down syndrome as well, I didn't have much training in this, but I learned an approach to the patient, and it was so valuable in being able to do what we do. The other thing, I think, I'm, as Tom is, I'm very biased towards family medicine I think our training in mental health and behavioral health is so valuable. Particularly when I went into a small town, the nature of the new doctor in the small town is everybody who has complex medical and psychological problems that are intertwined come to the new doctor, and so they used to. This was pre EMRs, but I would insist on looking at all their records, and some of them would be 5 feet tall of their paper charts, and I would go through those, wait till everyone went home and went to bed at night, and went back into the office and went through those. But very valuable to the training to sort through the mental health. And so certainly we do a lot of mental health treating in what we do with Down syndrome, and that was so valuable to be able to do that and to learn that in training. So I'm thrilled to be here today, because I think that family medicine just teaches us such a breadth of things, and you see people go and do lots of different things with the training, and I'm certainly an example of that's had real opportunities because of my family medicine background.
And I think you've teed up a couple of the questions that are in the chat for you. I think you kind of touched on a little bit about the transition from full scope family medicine to providing care for patients with Down syndrome. And just to your point, the fact that you started out with an idea and now it's an entire building at Lutheran General. It is not just an office or a couple of things. It is its own standalone building. To me, is just a phenomenal testament to what the need was. And secondly, the thing that both you and Dr. Cornwell mentioned was the advocacy side of things. Like, these things don't just happen. You have to get out there and speak up for the need and those people who were not going to be heard unless someone spoke for them. So with that, maybe you can hit those two questions, including Dr. Cornwell's about concerns for patients in states where there are aid in dying.
Yeah, I would, I half joke, that we're not really expected to be in the black. We're definitely in the red when it comes to the finances of the clinic, but it is part of the mission of a faith-based healthcare system. They do remind me periodically we don't need to lose quite so much money, but they're okay that we don't make more or less. So that really has been very helpful to have the support. Just as Tom discussed the support of Northwestern, we really have the supportive advocate to do what we're doing, which has been very helpful. I see the question about transition from practicing full scope family medicine. It is interesting that my two loves at the beginning were peds and OB, and I don't do either one of those now. I do primarily adult medicine. I do see some adolescents, but it was a community that needed service, and it was presented itself as an opportunity, and just sort of fell in love with it and just ran with it, and was very fortunate to have support. Tom asked about the concerns about assisted suicide. Yeah, that is a potential concern, but this community has been dealing with it for a long time. In fact, I was reading an article this morning, and it was a term I had not seen before, but it was called passive euthanasia, where by not providing care, we're sort of promoting people to die. And then certainly when I was a medical student in 1984, 83, 84 was when you may or may not be familiar with this, something called the baby doe law came. There was a baby in Indiana that had Down syndrome and tracheoesophageal fistula that was basically stuck in the corner of the nursery and allowed to starve to death. And a nurse there was appropriately concerned, and they actually went to Washington, and it ended up being a bill that passed ultimately, and that's called the baby doe law, that just because a child has a disability does not mean that they get excluded from care. That child unfortunately died because by the time all that went through the process, it was too late for that child. But so that's in place. But certainly during the pandemic, our experience with the encouraging people to be DNR, and certainly the experience seen in the 800 plus hospitals that study. I'm actually going to be in Washington next week talking to some folks advocating on the issue with regards to transplants for people with Down syndrome, which is another issue where people with Down syndrome get excluded from care. And again, it's sort of a passive euthanasia sort of approach to treatment. So I don't know. We'll have to see what happens with the assisted suicide, but we already have a problem we're trying to deal with the other the others. So that'll just be one more thing to try to address.
That's unbelievable. I'm going to go ahead. If you're able to stick around, I want,
Please,
please,
thank you.
that'd be great. I want to go ahead and bring in Dr. Josh Carpenter, and all of you who can stick around, be sure to have questions for all of them. I'm going to bring in Dr. Josh Carpenter, and here he is, and there he is.
Hey guys, so I've got kind of a unique job that doesn't necessarily fall squarely within family medicine, but is definitely built for family medicine. I am the Chief of Aerospace Medicine at the 182nd Air Wing. We are part of the Illinois Air National Guard. We've got 3 wings across the state and fall under both a federal and state mission. My background to get into this, I enlisted in the Air Guard. Initially was in satellite and wideband systems for a combat comm squadron back in 1999. So I've got 25 years. I'll be finishing up this year, and converted over to the medical corps when I entered med school. We support both federal and state missions, and I'll highlight that a little bit later. But family medicine really is ideal for this. One of the reasons is for the federal mission, we may be the only doc on a continent. And what I mean by that is we support the Operation Cool, which is the science teams that go down to Antarctica, where you will literally be the only physician on the continent, which is nice because you can brag that you are the best physician on the continent. We also have to lead multidisciplinary teams that are teams that really have nothing to do with what we've been trained on. Some of those examples are bioenvironmental engineering, and in my case, public health. I don't have an MPH, although there is some MPH training in the training that we go through. But the bioenvironmental engineering is kind of interesting. You're doing shop visits and you're encountering toxins and risks to individuals and trying to figure out how to mitigate those before they even become problems. Part of what we do in the clinic is we lead the care for both special warfare individuals and aviation career fields. And so that encompasses care for teams that you may have heard of, like in movies. I've in deployments, I've supported some Navy SEALs and some Green Berets, but my primary mission is to support my team with the C-130s. So we currently have H's, which have a seven-member team. And so when we deploy, we specialize in leading care for them. And that's a big part of that is advising leadership on operational risks. And so you can imagine when you've got multiple teams and multiple missions that you've got to accomplish, some of these missions are happening at all times of the day and night. And so part of what we do is help to mitigate fatigue with sleep, work, rest, cycles. Sometimes you have to do that with pharmacology. And so that's kind of one of the interesting areas. We are focused on human performance, where we are the go-to for leadership on things as simple as diet. And if you have paid any attention to the food is medicine movement, or the plant-based diet, that is actually, there's been a home for that within the Air Force, where one of the leaders for the American Board of Lifestyle Medicine actually came up through the Air Force. She was a flight surgeon over in Colorado. And continues to be one of the leaders for the Board of Lifestyle Medicine. One of the other interesting things about this job is that it's only part-time for me. There is the option to do active duty Air Force where you're on an air base, but my primary job is actually that I'm a hospitalist down in Galesburg, Illinois. Actually working, I'll be starting a new role as the managing medical director for them at the end of the month. But this is just a part-time commitment for me, where I will perform drills for them 2 out of 3 months. We do 3 days, and then any increased training that I need to do, and then stepping in with any deployments that they may need for kind of extracurriculars that way. I can take the next slide. I'll go over required training, and then I'll talk a little bit more about the picture and how that falls into the state mission. So for required training, you must be board certified. It doesn't necessarily have to be in family medicine, but I've got 3 family docs, including myself now. 4, sorry, we've got 4 family docs. I've got an ED doc, I've got a cardiologist, we've had a neurologist in the past. But the reason why we prefer family medicine is that they're going to be the most versatile when you're going to a more austere environment where you may not have a whole lot of resources. You guys probably already know family medicine is definitely the most flexible out there, and you get the best bang for your buck. Kind of talked about how the multidisciplinary team. If you're thinking about considering it, there is a kind of a pathway to this. So like I said, I initially enlisted, I went through basic training, and then I came back through. You do get a direct commission, but there is a commission officer training that you have to go through. That's somewhere between 4 and 6 weeks, depending on which course you go through. And that's down at Maxwell Air Force Base. And then to become a flight doc, it's a 6 to 8 week aerospace medicine primary. There's some courses that are a little bit unique to this, where you'll learn things about like aircraft mishaps and how to investigate if there is an aircraft mishap with regards to the human performance side. You're required to have ATLS. You actually get flight training. You'll leave the course with 10 hours of flight training. The most fun will be your PITS ride, which is a plane that you'd see in like an aerobatics performance at a air show. We do a fair amount of travel medicine and sort of a take on wilderness medicine. And we do have to go through SEER, which is similar to what the Aircrew and Special Forces go through for the survive, evade, resist, and escape. You are required to be able to hold a security clearance just because of the briefings. The picture on the right was actually, as that relates to state training, I got called up to head a multidisciplinary team shortly after COVID kicked off. And the team actually comprised mostly of civil engineers. We had plumbers, engineers, electricians. And what we actually did was we went through hospitals that had been shut down within the last 2 years to see if it were viable to reopen those by the state. This is the worst example that we had, where we actually had to gain access to it from the 3rd floor. This one we were not able to salvage, but we were able to find about 20 respirators and come up with over 150 beds that we could use, either intermediate level or higher. It also coincided with another undertaking that we had, where we were looking at converting hotels into mass casualty housing units, where we could provide lower level, kind of your more, not quite ambulatory, but requiring a little more care. And we were able to come up with about 15,000 beds in about 2 weeks in different regions of the state. So that was kind of a fun multidisciplinary exercise. I can take the next slide. So your daily kind of practice environment, we do routine acute care. On the guard side, not so much. It's more the occupational health. But if you're in a deployed setting, you're gonna be running more of a prompt care and routine acute care type picture. It will be a little bit more than a typical acute clinic, where you'll have kind of a sick bay, and you may have to stabilize some patients that are maybe a little bit more than what would normally come through. And that's why you're trained in ATLS. Deployed medicine is kind of that travel medicine, where you get to practice in an austere environment. My career has brought me to places like Syria and Iraq and Afghanistan, lots of places in the Middle East. Another big part of what we do is the critical care air transport team and the aeromedical evac. That's where we actually can convert the back of a C-130 or C-17 into an ICU to transport patients. One of the famous stories that you may or may not have heard of is there was a patient that had suffered some severe injuries in Afghanistan, and we were actually able to get him stabilized loaded. He required 80 units of blood en route, but he took off in Afghanistan and landed in Maryland and ended up surviving. it's kind of a neat thing to be able to be a part of something that is able to perform those sorts of logistics, but also can make some of the realities of our day-to-day jobs currently a little bit frustrating that we're able to do that, but not sometimes find a GI doc or a urologist for a patient to be seen in a timely manner. We also man field surgical teams where we're going out with anesthesia and surgeons to form a small 3-man team to be able to do rapid stabilizing surgeries. And then also spoke a little bit about some of the domestic response. We also do a CBRNE enhanced response force package here in the state of Illinois, and that's chemical, biological, radiation, nuclear, and environmental, where we can actually set up an ICU type setting within 48 hours of getting a call to include vents and a full package to take care of about 8 people at a time. Typically, that's just going to be for triage to get them moved to a different level of care. Generally, where we've seen this used most often is for hurricanes, and Illinois' package hasn't been activated. But that's a little bit of what we do for the Guard.
Just a few things that you do. There is a great question queued up for you in the chat from Dr. Mardini. Why you think family medicine is more sought after than emergency medicine in these particular roles?
Yeah, so emergency medicine, not all of what we do is really battlefield related. A lot of what we do is caring for people in an ambulatory setting. And so we are definitely more flexible. If you've ever talked to an ED doc that's treating someone for chronic conditions, there's sometimes a little bit out of their comfort zone. And so we really can provide a little bit more. In addition, when I was in residency, I did a lot of moonlighting in the ED, so I got fairly comfortable with the ATLS type stuff and that stabilization. It is something that is definitely within family medicine training, and so if it's something that you're comfortable with, you can practice through the Air Force in a little bit higher acuity settings if you want to. Now, you don't necessarily have to, because we carry a lot of flexibility for them, just being able to run more of an inpatient or even just a ambulatory setting, which is really the heavy lifting that we have to do.
Excellent. Thank you so much. And stick around if you can. I want to bring it home to our 4th panelist for the day, the alum from the Northwestern Family Medicine Residency Program there. Dr. Sajdev, if you can unmute and bring us home, and then we'll take any questions you have and provide a few extra resources that might help you on your journey.
All right, sounds good. I am really excited to be here with you today because, as Jenny said, I'm a graduate. And when I was thinking about the topic of the session and like, where can you go with family medicine? I really think Jenny said it at the beginning. It's anywhere and it's anything. You can do so much with the Family Med Foundation. And so for me, what I will say is that I could not have imagined that I'd be where I am today when I was sitting in your shoes about 10 years ago. And I definitely never would have thought that that's where I was going to be before that when I was in residency. Hi, Dr. Benavente. I'm very excited that he's on as well. We were co-residents together. To me, he's still Chris. So just to share a little bit about like what I do in my path, I really think there's sort of 3 pieces of my journey and the work I've done in my career. The first being public health. I was a public health major. I thought that would be my path. I thought I'd work in government or health policy, but I realized that I saw some really amazing work being done in public health by physicians. So I decided to go to med school, and I did a post-bac. I, during my lag year, worked on a healthcare disparities grant at a large FQHC in New York City. And for me, that really made me want to do primary care and specifically work in an FQHC or in a community health center type of setting. So I went to medical school knowing that I wanted to be a family doc and knowing that I would want to look for a residency that would let me have that practice setting when I was done. And so I went to Northwestern, and that's sort of what I'll call the clinical medicine portion of my career, where I did the residency. I really learned a lot. I have still in touch with some of my co-residents. We still have a very active group chat, so please keep your relationships after you graduate. And then when I graduated, I wasn't quite ready to give up inpatient medicine. So I'm from Philadelphia originally, and I took a role as a faculty where I could do inpatient and outpatient precept. I really liked education and doing some of the mentorship work. And I also was able to do some obesity medicine in my practice. And to me, that felt like it had a component of prevention and some public health links there. And then after about 2 years, I realized that I really missed that larger population level impact that public health has and that lens. And so when I hit that mark, I said, you know what, I need to figure out what else might be out there for me. So I took a break, and through some networking, got connected to a colleague in my unit where I'm at right now at the American Medical Association. So I work full-time for the AMA. My role is as the Director of Clinical Engagement and Equitable Care. I've been here over 6 years now, and I'll share a little bit more about my work in a minute. But early on, I realized that I would want to get some additional training. And I always thought it would be an MPH or an MBA, but I realized that I was potentially not going back to practice. And so I thought it'd be really nice to have some additional skills. And so I met someone who was doing health communications. And I feel like it was this little light bulb where I was like, this is so cool. I can go learn something completely different that's really applicable to what I do. And it was. So I have a master's in communications, and everything I learned in that program, I found really practical to the work I was doing on a day-to-day basis. And so it made it really fun, and it made it really rewarding to do that. And so the role I'm in right now, I'm in this unit of the AMA called Improving Health Outcomes. And I think I did not know this before I joined the AMA, and I think a lot of people don't know that our mission is to promote the art and science of medicine and the betterment of public health. And so my unit is really dedicated to furthering the goals and the mission of the AMA. We're focused specifically on cardiovascular disease prevention, and a lot of our work, because of that, centers around hypertension and improving blood pressure control. So in my role, I say I have about 3 focus areas to what I do. One piece is working with physicians and care teams and overseeing coaching and providing coaching around quality improvement as it relates to improving blood pressure control. Another big component of my work is in conceptualizing and creating clinical content. And then the last piece of my work is really centering and embedding equity in what we do. And so I'll say I use all 3 components here of my career path: my public health background and experience, my foundation of family medicine. I agree with all my colleagues that it really is very flexible training to have, and it really does allow you to have the career that you didn't know you wanted, but you end up having. And then I also use my communication skills and expertise. So I'm happy to take any questions, but I think the answer again is, what can you do with family medicine? It really is anything and everything. And I think that's really exciting to think about.
Thank you so very much. We've got a couple minutes, so I want to make sure anyone who has any questions of any of our panelists, unmute, say hello, put it in the chat. I do have some additional resources that may help you with some of these questions as you're looking towards your next chapter, but if anyone has any questions, now's a great time to ask. And just a little fun fact, if you didn't know, the current AAFP resident on the board of directors is a Northwestern resident, Dr. Walcone, out of the Grays Lake program. So that's just a nice tip of the hat to the kind of leadership that is being produced here in Illinois, and specifically through the Northwestern programs. While you're thinking of some questions, just want to make you aware, we do have a career center through IAFP right off our website. free for members. There's lots of ways you can tailor your search. You can have your resume available for potential employers. It's a great place if you're not really sure what you want to do, but maybe where you want to go as far as geographic requirements. That's a good place to start. And then AAFP has really put together a lot of great materials in the last couple of months for early career physicians. Here's just an example, some things to look for when you're evaluating contract offers or potential employers when you're narrowing down your search. And all these slides have been sent to Dr. Murphy, so you'll get all of them. And then on the flip side of that, the red flags, the things, the danger signs that you may want to either look more closely or change your direction. There is a question in there from Dr. Liu for all the panelists, the defining situation or moment that allowed you to know that you are on the right path. And any of you can take it as you'd like.
I can start, and I'll say that I don't know that there is one. I'll be honest. I think kind of figure it out as you go. And in the moment, one of the things that's really nice is that if it doesn't work, you can try something else. And so for me, I suspect I'll be figuring out my career for the rest of my career. And so that's what I'd say.
Yeah, I think for me, it's probably the same, where it's a continual evaluation. Things that you do that give you energy are things that you should lean in towards. And that's going to continually change throughout your career. And don't be afraid to say that, this thing that I'm doing, whatever it may be, doesn't feel right. And steer yourself away from those. In addition to the other jobs I mentioned, I also picked up being a medical director for a developmentally disabled group home network here in Galesburg. And I've got to tell you, that was probably the number one decision that I made to bring me out of burnout, and has brought me more joy in my career than anything else. And it was at a time where I wasn't sure I could handle anything else, but I leaned into something that felt right, and it completely helped with my career. So don't be afraid to lean into whatever feels right.
I would just add that I absolutely loved being a family doc in a small town, but I knew at the moment when I knew that I could never go back and do family medicine again, because I loved so much what I was doing, that I was in the right place.
I love that. Those are wonderful answers. Oh, another question in the chat. If residents are interested in exploring these career opportunities during the next year, are there specific opportunities that might be able to access, such as electives?
Yeah, I would just say reach out to me and we can sort something out. Not that I should do a free advertising, but I started residency 40 years ago this summer. So you do the math. I'm not young. So if you're really interested in this field, let me know.
And if you're in a place where you're going to be thinking about what you want to do when you grow up, as family physicians do ask themselves, I think more than once, this new benchmarking tool that AAFP has, you can kind of filter things by a lot of different variables, whether it's full-time, part-time, certain location, skill set, inpatient. You can kind of plug in a lot of variables and it'll give you some feedback, such as average compensation. You can do it for where you are in your career path, if you're just out of residency, if you're mid-career. So you can kind of get a lot of data there, and that also helps. Just a couple little things I want to make sure I get to, and we can keep the questions open as long as you have them. Those of you who are the PGY3s, congratulations. Just a heads up, you're going to be getting an email from the Academy where you can update your contact information with us. If you're staying, wonderful. We will be so happy to have you as an active member. And if you're moving on to another state, we'll make sure AAFP has that information to help you transition to your new state. And if you're looking for some fun things to do in the next couple weeks, we have an annual White Sox game that we do every year. This will be number 17. And the only year we didn't have it was 2020. So there's information about that. And we've added a Chicago Sky WNBA game in August, which I think is going to be super exciting for women's sports and for just a fun, family-friendly way to bring us all together for a day. And then our award season is underway. So especially those of you who work with great physicians and great educators, it's an easy online form. They're not due till July 1st, but just know that that's out there. AAFP National Conference is coming up this year. It's August 1st through 3rd. So some of you may be there on behalf of your residency programs or going for yourself, looking for that next step. So I will see you there if you are there. And if you have some great stuff to share that you've been working on, the call for abstracts is still open at Family Medicine Midwest until May 28th. The conference itself is up in Madison. We had it there in 2018. It's a lot of fun. It's a great place to get out and get amongst your colleagues from the different Midwest states, share what you've been doing and learn what they've been doing. And then, of course, our annual meeting is coming up in November. So if you are still in residency or still in Illinois, we hope to see you there. And just something else that we've been doing that's been kind of fun, and Dr. Carpenter has been a huge part of this, was our new physicians and new parents webinars and discussion groups. So being a new physician is one thing, and being a new parent is something, and trying to do them both at once, wow. So there's some great resources there. That's on our website. That there's 2 years of webinar recordings and a lot of great tips, including from our own Dr. Carpenter. Here's where you can find us all the time online. And then I threw these in for fun. I had this presentation from AAFP where they showed a bunch of like, what can family physicians do? And Dr. Cornwell was one of the ones in AAFP's slide deck, but there's a whole bunch of them. Working overseas and working for the CDC and working for Wonka. So I put all these on the end of the slide deck for you guys to see. Dr. Izzy Lowell does all gender affirming care all virtually in states where they can't get it in their own state. They can get help from her. So there's just a whole bunch of these things. So what can you do in family medicine? Oh my gosh, win a Super Bowl. That's a family physician with the Seattle Seahawks. So there you go. There's a whole bunch of stuff. We definitely enjoyed this opportunity to check with you. I'm going to stop sharing and leave it open. Dr. Carpenter, I saw threw a little something in the chat. To reach out. If it wasn't in the slides, reach out to me. I will make sure to get you all connected. That's what I love to do. Any closing questions or any final thoughts from our panelists? We are right up at 5:30, which is amazing since we started late. So. All right. Well, thank you all very, very much. I'll stop the